All right, so we're going to launch right into it. First thing is cardiovascular surgery, okay? How to deal with the patients. We're going to touch on three major topics. One of them is weaning. So as you might know by now, we do a completely different weaning method for cardiovascular surgery patients. What are cardiovascular surgery? Cabbages, LVADs, valves. So basically, any surgery that involves the cardiovascular surgery team. The second part is going to be INO, and INO is going to be, INO is going to be important in SI. You may have had some experience in MI, but I want to make sure you have a better understanding of it and the setup going into your SI precepting. And then lastly, FIC. So we do two-part FICs in SI, and I just want to go over all of that with you. So let's start with the first part. So I'm going to share my screen here, and let's see if I can find the right file. I'll share my desktop. Here we are. Okay. Can everybody see this?
Yes.
Okay. So cardiac weaning is often referred to as rapid track. It's just an order set, okay? It's not a policy, it's not a protocol. It can and will be referred to as a policy or a protocol, but it really isn't. It's just an order set. So anything that we have a policy for, we could have decided to just have the physician write it into the orders, and then we wouldn't need a policy. So what the policy is for is if we want to use a keyword like vent management protocol, and that triggers an entire policy that has a protocol attached. In this case, we just built it out as an order set with the CV surgery team. So it's just a different way to go about it. What I did in this file here to introduce it to you is I just gave you screenshots of all of the parts of the order set. But really what you want to look at is some of the bullets that I have here. So basically, when you get a patient dropped off by anesthesia, you'll be told by the nurse 20 minutes ahead or an hour ahead, hey, set up a vent, patient's coming. When they come, you want to make sure you get your orders. If the patient's on INO, you want orders for INO. You want to verify that the patient has the rapid track order set in, okay? Rapid means less than 6 hours. So this is not just some soft target. This is a hard goal. It doesn't mean that we always accomplish that goal, but we want to get our extubations less than 6 hours if at all possible. So this is a value-based purchasing quality measure. What that means is if we're not achieving this goal a certain percentage of the time with our cases, then we'll cease to become a preferred provider from a certain payers. Like certain insurance might just move to scripts from Sharp if we're not able to achieve our quality goals. So this is very important. So if you hear the term the extubating within the 6-hour window, that's what that's about. And again, nursing is always going to be, communicating with nursing is always going to be key. So as you see here, very basic vent settings, the same as what you're used to. You're going to use ASV, put them on PIPA 5, 50%, get them on end tidal, and get a gas. So in this respect, it's so far the same. You land the patient, make sure you have, make sure you know what your orders are. You put the patient on your initial vent settings. We do want to try to use end tidal when and if at all possible. Now, we now have end tidal at every bedside, so we can no longer really say the equipment's not available. So we really need end tidal, and we need it before the first gas, because obviously end tidal is not nearly as useful unless you're correlating it with the ABGs. So obviously after this first blood gas, you're going to adjust the minute ventilation to hit your targets. Check your ET tube. Always collaborate with the nurse on getting the order and the page out to X-ray. That's where they can be very helpful. We have a lot going on, and so do they when they land the patient, but they will page X-ray. That's kind of their task to take kind of off our hands. But we want to follow up, make sure it's there, make sure you check the tube, and make sure you adjust it. Sometimes they'll come out with a little piece of pink tape. The tube will be barely hanging there. I would recommend changing it right away and then adjusting the tube after the X-ray. However, you just want to make sure that when that X-ray is taken, that you know where the tube actually is at that moment. If it's flopping all over the place, you want to make sure it's secured in a very particular spot when that X-ray is taken. Otherwise, you still don't know where you're going. All right, so if you see here, we want end tidal continuously titrated to get a CO2 of 45 to 55, right? And then it says 35, PCO2 of 45 to 55 or 35 to 45 as estimated by the end tidal. So they're assuming that the end tidal is going to be 10 or 5 below. It's kind of a pretty big assumption, but you know that if you're targeting around 45 for the CO2, you should be good. And it's usually not a problem. You might have to go up to ASV 120. You just do what you do, cross multiply, put a little note in, make the change. After that, there's going to be a pause, okay? You've checked the ET tube, you've done the ABG, you've adjusted the vent settings, you've suctioned, you've secured. There's going to be a pause because the patient needs to get hemodynamically stable. Now, this could take 30 minutes or it can take a couple hours. That means the patient needs to warm up, wake up potentially, but mostly get hemodynamically stable. So the nurse is going to kind of be the one to control that aspect. However, with our 6-hour window, it can come up quick on us. So I would encourage you to check back within or right around the 2-hour mark and just say, okay, where are we? I'm ready to go with the SBT. Whenever you're ready, let's do this thing. And then if they say I'm not ready yet, that's when you need to start coming back maybe every 30 minutes or every 45 minutes, because we don't want to run the clock out to 4.5, 5 hours and then be up against the gun. Okay, now here's where the difference lies. An SBT for CV surgery patients is 30 minutes on a CPAP of 5. Okay. After that, you're going to get a gas. After that, you're going to extubate. So it's almost like the opposite of SBT. So SBT, you do a long SBT on CPAP. You don't get an ABG. You do call the physician for extubation orders. With this, it's a short SBT. You do get a gas without calling, and you don't call the physician for an extubation order. Okay. And the criteria below, as I'm pointing to here, for extubation is rather broad, okay? So 72755 is a pretty lax parameters to extubate. So if you can imagine your blood gas comes back in at 72854, you might kind of second guess yourself. Well, you probably should. You probably should also make sure that the respiratory rate isn't too high. We used to use rapid shallow breathing index. The principle still stands. You want to make sure that the tidal volumes are somewhat adequate. I wouldn't feel too comfortable extubating a patient unless it's a tiny lady with a tidal volume of less than 300, really. I might go 250 for a tiny lady. But rapid shallow breathing index will kind of say that you want respiratory rates under 35, definitely, hopefully under 30, and tidal volume around or higher than 300. And then the most important, or one of the most important, because the physician is not going to cue you, you're not even going to call them, you need to assess the responsiveness to verbal commands, cough and gag, and leak tests. So all of these things need to be very carefully assessed before you extubate. Now, you want to involve the nurse with this because they're doing this every day. You guys are just getting started. With the aspect of knowing when you're ready to extubate by the parameters, you probably are the expert. But when it comes to really making sure that patient is following verbal commands properly and appropriately, for that, you kind of want to work collaboratively with nursing. You want to always make sure they're on board with your move, because if things go south, and they can, then you want to be on the same side and on the same team. So definitely defer to nursing or collaborate with nursing on deciding whether the patient has adequate responsiveness. All right, scrolling down. Here is the CPAP parameters. So they're asking for rapid shallow less than 106, which was our old standard, and they're asking for respiratory rate of less than 24. So there you go. You want to make sure that they're not breathing a mile a minute. So if the patient is not meeting the parameters, you go back to ASV. You go back to the prior settings where you had a good blood gas, and you really need to keep repeating the CPAP trial. And that goes for night shifts straight through the night. We need to keep repeating, keep the pressure on, because even past 6 hours, there's another benchmark at 24 hours. So we want to make sure we're not sitting on it and assuming that this patient failed. Now we're just going to wait to see what they want to do in the morning. No, that's not the right course of action. You need to repeat another trial within 2 to 4 hours. All right. And I just want to take a moment here. So as soon as you get the patient extubated, you go straight into hyperinflation. You collaborate again with the nurse. You bring them an IS. You ask them, hey, can you help assess once the patient's fully sitting up and awake? You loop back and see how they're doing, and then go from there. Any questions on what we've talked about so far?
Is it possible to get you to email us this these
I
printouts?
already have. I did that
Thanks.
this morning. So all of the attachments we're looking at are in your email right now.
Fantastic.
So when you get into SICU, don't be intimidated. Don't listen to people that might tell you that, oh, in SI, they're more intense and they'll really be on you for everything. That really isn't the case. The one thing that I would tell you is that you can't kind of slink in and out of your room, jot down your numbers, and kind of go about your business. That's not the culture there, and you will be extremely uncomfortable in SI if you try to do your care that way. Hopefully, you're not doing that in MI either, but particularly in SI, you might be asked on your first day there, who are you? And they actually just really want to know who you are. And then once you introduce yourself, and then you're part of the team. There's very few, if any, nurses down there these days that you're going to have any problems with. As long as you're open and you're communicating throughout the whole care of the patient, that's what they're used to. Almost over communicating, really being collaborative in every part of the care, and you'll do great down there. All right, if there's no questions on that, I want to talk about I&O. Has everybody done I&O in MI?
Yes.
Has anybody not done I&O in MI? Okay. Has everybody seen or landed a patient that was on I&O coming from surgery getting bagged by anesthesia?
No.
No.
Not recently.
But you kind of know what I'm talking about?
Yeah.
Okay. Everybody else?
I've charted INO.
You've charted it. Okay.
It's already set up and in use, and I know how to chart it, but setting it up, calibrating it is new.
Okay.
Yeah, same. I haven't started one.
Okay. So I'm going to show you this video. It's long. It's like 11 minutes long. It's a little bit boring, but I think it's important. What needs to happen is you need to, at some point, grab someone that knows what they're doing and have them show you how to put the injector in line and put the sensor in line. This is important because these patients are going to come out. You might not even know your patient's on INO. You're told, hey, there's a cabbage coming out, get a vent ready. You have it on standby, you think you're good. Patient comes out, anesthesia is bagging off the INO machine. All the parts are all in a giant spaghetti. Doctors are all in the room. Everyone's looking at you. Doctor's bagging the patient, waiting for you to get the INO in line with the vent. So what you want to do is you want to be able to do that kind of blind, like half asleep, middle of night shift, whatever. You want to just do that like autopilot. It's not hard. It's actually quite easy, but one or two dry runs is going to really set you ahead of the curve on that. Okay. If you get in that situation, don't hesitate to ask for backup, okay? Because your first 1, 2, 3 times, you're going to want somebody there. But what you don't want to do is you don't want to let that person, don't let your lead take over. Don't let even your preceptor take over. Have them stand by the door or by the toilet there in the room, just in case, you fumble. You know that person's there. You want to actually do it yourself right away if possible. Jump into the deep end, know that they have your back. That's the way that you're going to learn this. Before we watch the video on setup, I just want you to kind of reflect back on the scenario we're talking about. Patients coming out of the OR, anesthesia is there, hustle, bustle, the nurse is asking 20 questions. You don't want the physicians to walk away without getting an INO order and an INO weaning order. Okay. It's important. We're using this drug off label. You do not want the order not to be in. It's under your purview. You're administering this medication. If the order is not in, it'll come back at you later on. Technically, yeah, the physician is the one that's actually prescribing this. They should technically be putting the order in, and sometimes they do, but often they don't. And sometimes they just put in an order that says INO, and so this isn't going to be adequate. What'll happen is they'll walk away and they'll just say, okay, wean it to off in a couple hours. And so you're going to have to stop them, and you're going to have to kind of control the conversation for a minute. Okay. So 99 out of 100 patients are going to come out on 20 parts. You can wean from 20 to 10 to 5. 5 parts is pretty much the same as 20 parts clinically. Okay. So when they tell you to cut it in half to 5, it means 20 to 10 to 5. And then they'll usually say, go by 1 part, Q1 hour, okay, as tolerated. And then you want to know, is that to off, or is that to, sometimes they want you to hold at a certain level. Then what does as tolerated mean? So you want to ask by what criteria? Mean airway, mean arterial pressure or pulmonary artery pressure are the two main ones. They'll give you numbers. They're different numbers every time, and there's a reason for that, because sometimes these patients are coming in with pulmonary artery pressures before surgery of 50. All right, so we're not working in the normal world here. So you want to nail them down for actual criteria by which they want us to hold weaning. Okay. And again, nursing is familiar with all of this. They're used to, this is put in as a communication order. You can put it in as a communication order, but if at all possible, have this conversation with the nurse present and listening, so that you guys can make sure you have both ears and minds kind of working on this and getting it straight. Probably sounds very complicated right now. It's actually pretty straightforward. The one thing you just want to remember is order for INO, order to wean by what step down measures. So order for INO, order for wean, and by what criteria. Okay. So let's look at this. Is everybody still with me?
Yes.
Yes.
Yeah.
Okay, cool. Is there really music on this video?
I cannot hear.
Okay, we're good.
She's muted.
Yeah, I cannot hear what she's saying.
You can't?
Can't.
Uh-oh.
No.
Oh boy. Okay. Okay. This is what we're gonna do. Whoa, what just happened here?
I think you press next.
Uh-oh. Who knows what's gonna play now? Better pause this before I'm in trouble. I'm gonna have to do the commentary on this, unfortunately.
Why is
see
it
it.
not playing? Like, why the voice is not showing? Weird.
I don't know. Let me see if I can figure this out here. Oh,
There you
is this gonna work?
go. Hopefully. Nope. Yep. There we go.
Is that working?
Yeah.
Yeah, I heard something, but can you can it be louder? Still very low. Barely hear it.
So in the back of your INO, you have your power
That's
source.
good.
Is that better?
Yeah. You want to start it over from the beginning?
Your power, turn that on,
Okay, 1 second.
and then you want to connect to your regulator to your INO tank. Patient gas sample, and for the startup of your INO, you will have a packet in the back of your machine.
Okay, can everybody hear?
Yeah.
Yes.
Okay, cool.
You will need adapter gas sample T, the water separator cartridge, line patient gas sample, the 15mm adapter, the blue corrugated tubing, the injector tube, and also you will need the oxygen tubing. So on the back of your INO, you have your power source. You're going to plug it into the outlet. This is your power. Turn that on. And then you want to connect to your regulator to your INO tank. And you're going to make sure your valve is closed. Then you're going to come to the front of the machine. So your battery life on your INO will last you about 6 hours. So we're going to wait for the startup and the prompts. And we're getting ready to purge. you see that the screen is telling you that you have your initial connections, step 1 through 8. So you're going to confirm that the water trap bottle and the water separator cartridge are in place, which are right here. You're going to connect the patient sample. Next, that we've connected. So we're going to connect the injector module cable to the tubing and the injector module to the INO DSIR, which is already connected. We're going to hit next. So we're going to verify the power source indicator light is illuminated green, which is right here. Confirm that the INO DSIR card mirror cable, our transfer regulator cap assembly is connected to the INO DSIR inferior cable inlet. So that cable will be connected with your INO tank. We're going to connect it in. Now purging is beginning and it says alarm rate activate. Okay, it says open the cylinder valve. Then assemble pre-use setup connector and tubing. Set the O2 flow meter to 10 liters. Set it to 10 liters. Turn integrated backup on 250 ml per minute, which is this one. Turn it on to 250. Go hit next. And then allow values to stabilize. You have to verify that the model values are the NO2 less than 1.0 ppm and the nitric is between 14 to 26 ppm. So as you can see, the NO2 is less than the 1.0 and then the NO is between the 14 to 26 parts per million. Backup delivery test complete. Turn integrated backup off. So this is the backup, so you have to turn it off. And then you have the flow meter set to 10 liters. It is, which is already set to 10 liters. And then press next button to automatically set INOmax dose to 40 ppm. Okay, so now we have to verify that the O2 flow meter is set to 10 liters per minute, which is wherever you connected it to. That's set to 10. Then press next button to automatically set INOmax dose to 40. So you set dose to 40. To stabilize. So you have to make sure that the FiO2 right here is between 92 to 98. The NO2 parts per million is like less than 1.5 parts per million. And then the NO is between 35 to 45 parts per million. So you're going to have to wait for a little bit. Once it's stabilized, the O2 is between the 92 to 98. The NO2 is less than 1.5, and then the NO is between 35 to 45 parts per million. And then once it's done, you turn the INOmax dose to 0, which is this one, back to 0. And then turn off the flow meter, which is flow from previous setup and reconnect connectors. And then set the INO blender dose to 40 parts per million and O2 flow to 10 liters per million. So now we have to turn the O2 flow meter off, and we have to remove it from the previous oxygenation tubing from the O2 flow meter and connect it to the front of the INO blender, which is this one. So we have to turn that off and then take it off and put it in front of the INO blender. Then remove the injector module from the previous setup and reconnect connectors. So now set the INO blender dose to 40 parts per million and O2 flow to 10 liters per minute. So once this is all set here and connected, we turn the nitric to 40 parts per million, and then this flow, we turn it up to 10. Allow monitor value to stabilize. You have to verify that the monitor value is between 32 to 40 per million for the nitric. Okay, so if you do have to use your INO, this is how you connect it to your ventilator. So you're going to take it off your inspiratory limb, connect it right there. That's going to go there. And you have your inspiratory limb here as well. And you're going to need that 15 adapter. And that is your setup. So when the patient's coming out of the OR, they're already going to be on the INO, so all you need to do is do the same setup. And you're going to grab your ambu bag. The ambu bag is going to be connected into your INO blender. And in case of emergency, if you have to bag the patient, you want to set the INO to the amount of parts per million that you're using and increase your flow to 10. The diagram that my INO is running to my patient. So let's say that I've already come on, patient's already been on, and I'm getting a report. So I need to do a low calibration. So I'm going to hit the little folder. And it's going to tell me when the last time my high cal was done. So I know that it's not due till June 17th. So I'm still good. So I'm going to hit my low cal, and it's going to take me through a prompt. So if you ever want to cancel the low cal, you just hit cancel. So this is our presentation on INO. I hope you enjoyed the video, and me and Jill. We just worked 12-hour shifts, so we're like really tired.
Hello.
Hello?
Hey, so let me stop this. So before we go into questions on this, there's a couple things you should know. What you saw was the initial setup. So you'll do initial setup not when the patient is coming from the OR, because they will have been using the setup in the OR already. They'll come out bagging the patient off the INO machine. So they will have done all of those steps except for putting the injector in line and the sample line in line with your vent circuit. Everything will already have been done. If you're starting an INO on a patient that, say, all of a sudden the surgeon decides, hey, we want to start INO on this patient that's been here for a while, or maybe the patient is having oxygenation issues and one of the pulmonologists wants to try INO on the patient, then you're going to have to set it up as you saw in the video. The second thing I want you to know is that that video makes it look 20 times as complicated as what it really is. And the reason is it looked like they really knew all of this stuff like the back of their hand, but what you didn't really wasn't super evident in the video is that they were just reading the screen. And that's all you'll be doing, is you'll be reading the screen and hitting the next button. The machine pretty much does everything, with the exception of you'll put the injector onto the sample port at one point and you'll run 10 liters of flow through it. And at that step, there's a little diagram that they didn't show in the video that you can click show diagram and it'll show you exactly how to set that up. And all of the parts that are needed for that are on the back of the INO. Questions? So the goal with precepting is going to be to get exposure to this as much as you possibly can while you have a preceptor standing right there. So I would encourage you to just grab, in SI, there's one or two INOs sitting in the alcove. Just grab one, have your preceptor stand there while you put the injector on the clean vent that's sitting right next to it in the alcove. Just practice putting it in line. Injector goes on the inspiratory side at the vent level with the arrow going down towards the patient, and the sample port line goes 100 cc's back on the inspiratory limb, 100 cc's back from the Y on the inspiratory limb. If you put it on the expiratory limb, it's pretty major problems because it's a feedback loop. So what the sample port senses tells the INO, hey, you got to titrate up or titrate down to hit your 20 parts. If it's on the exhalation side, it's going to go wonky and you won't get good measures.
Tice?
Yeah.
So when they were talking about the example of their being bagged on INO, are they bringing us the tank setup or are we setting up our own?
They're going to wheel out the actual INO unit that you're going to use in the room.
Okay.
And they're going to have their ambu bag hooked up to the main where you saw Jill and Latasha hook up the ambu bag, where you're going to be hooking it up for emergency. They're going to be bagging off of that port. Okay. All right, ready to move to the next topic?
Ready.
All right, here we go. FIC. Who has not or does not feel comfortable drawing off of an art line? Anybody? Everybody does?
Easy peasy pie.
Okay, good. So I'm gonna show this video because it's only a minute and a half long and it's very good, and I'll probably just narrate it myself. But so this is gonna show an art line draw, and they actually miss a step. So I'm gonna ask you what step they missed after the video. And we're gonna talk about FIC and what it is and why it's important to the CV surgery people. after this. But first, this is just a quick review on art lines. Here we go. All right. Does it look familiar? Do you see the vamp up there? It's kind of like our setup. So what's the first step's going to be? Pull back on the vamp, right? To get blood up there. And then you might want to silence the alarm first too, because when we start messing around, it's going to alarm. And usually I let the nurse know I'm drawing, because sometimes they want to draw a blood, to have a drop of blood, or they might want to draw some labs at the same time. Now that should have filled up with red blood right there, but because it's a rubber arm, I'm guessing it's not, but it should be bright red. And then they're pulling back here, or it should be self-filling, right? So they're showing that they wasted maybe, but you shouldn't have to waste because it's on the vamp carries the waste. There's a couple things I don't like about this video, but it's the best video I could find that shows the complete setup. So when you're done, you go squeeze it back down. All right. And then what's the last step? Pigtail, right? Flush it out and then confirm that the blood clears out to the patient level so that nothing clots off. And then you can unsilence the alarm. Now, 1 second here. I hate how it does this. So, does anybody know what step was skipped?
I feel like
Didn't close it.
yeah.
Didn't close it. Does everybody get that part?
Close what?
Yeah,
That part.
Close the
the
line.
the line. You have to
Yeah.
close communication.
Mhm.
So,
And then wipe it.
The little white
yes,
Uh,
yes.
Yeah,
Stop
you're supposed
talk.
to close it. Yeah.
Yeah. So, almost even more important, whoever said wipe, I think that's like of the utmost importance, because we're talking about arterial access line here. We need to use the alcohol and really scrub that port before and after. But yeah, the step that I was actually looking for, you're right, is closing the line. So basically, when we pull that vamp, we're pulling waste into that vamp, and it's mostly just the saline that's running in, right? So once you pull the waste, you have diluted blood and arterial blood in that vamp. You want to close that stopcock that's just proximal to the vamp, because you don't want any of that saline washing back. You'll have a diluted blood gas sample if you don't lock that. When you lock it, it's going to make the art line alarm, so you definitely probably want to silence it, or at least let someone know, hey, it's alarming because I'm doing this. You draw your blood. First thing you're going to need to do after that is open the line again, squeeze the vamp, pull the pigtail, and like I said, you want to wipe the port after also. Okay, let's talk about fix. I made this little screenshot thing. So you guys might be used to doing a FIC as a mixed venous blood gas, okay? In MICU, they'll ask you to do a mixed venous blood gas, and they'll call it a FIC, all right? In SICU, it's not going to be like that. You're going to do a 2-part FIC, and the 2 parts are an arterial blood gas and a mixed venous blood gas, okay? And what they're trying to calculate is cardiac output. So basically, if we put the mixed venous, the O2 consumption over mixed venous, right, times 10, whatever that means, you're going to get an estimation of cardiac output in liters per minute. It's actually not a very good estimate, but neither is a SWAN. Like what we used to do is we used to put a SWAN, a catheter that threads all the way up through the right heart and wedges in the pulmonary artery. We used to put this swan in every patient. We still have swans in some patients. And what they do is they inject cold ice water in there, and then they measure the degree to which it warms up as it goes through, and it measures the cardiac output. Everybody thinks that people tend to think that the swan is like the gold standard, and it kind of is, but yet it's famously not reliable. Neither is cardiac output using the FIC, but it's all we got. And when these physicians are trying to figure out how to land their patient post-surgery and make sure they have a cardiac output, make sure the patient's perfusing, they have full control of that with the drips. The nurse has full control of it, but we're flying blind, and you know, even with a swan, it's not reliable. FIC isn't that reliable, but that's what we're kind of basing the titration of these drips off of. So when we do these FICs, it's actually very, very important that we don't report the wrong number or make an error. Okay, so I'm going to show you how to keep yourself safe from making any sort of error. First thing is, you're going to get the arterial blood at the exact same time that the nurse is getting the mixed venous blood. So they're pulling off of a PA distal port, and you're going to be pulling off either the A line or you're going to be doing a stick. If you're doing a stick, it gets really tricky because you have to have them ready to pull, and then you're going to stick and say go, and they're going to pull at the same time. You have to get that sample at the exact same second in time. Otherwise, it's going to be a completely erroneous sample. You're going to run both samples, one arterial and one mixed venous. This is the mixed venous button, so definitely don't use the venous. And then the big thing that you need to remember that'll really screw things up if you don't do it right is draw time. So what I do is I'll maybe run the ABG part first, and then it'll be the draw time will be whatever time it is, whatever time pops up, 750, and I'll just remember 750, 750, 750. Okay. Then when that's all run, then I run my mixed venous, hit the mixed venous button, and then this screen pops up, and the first thing I do is put in 750, not 751. You want to put the exact same time. Otherwise, Cerner doesn't know to capture it and line it up and do the calculation. Oh shoot, where is my screenshot thingy bob? This is not good. Maybe it's on this file. No, this is this file. Maybe it is on this file. Nope. Darn, I had a screenshot. There's another step that we need to take, and I'm actually going to go right into Cerner to show you this. And then, you know what? I'm not going to. I'm not going to go into Cerner because there's patient identifiers and I want to use this recording. So when you picture yourself in Cerner and you're in interactive view and you're doing your vent check, right? Well, below that are a bunch of other views besides respiratory. The next one will be vitals, okay? And that's where the nurse does their charting in interactive view. Everything from blood pressure and temperature and all of those things, it's under vitals. So right where you chart your vent check, if you look to the left, there are other categories that we never use, except we're going to use it this time. And one of those categories is vitals. I'm actually going to exit out of this before I hope. Great. Here we go. 1 second here. Try again. No, that's not what I want. Try harder, try harder. Okay, so when you click on the vitals screen, there will be all these subcategories, just like on our vent check screen. We have vent settings, vent monitoring, SBT, all of these subcategories. Well, theirs will have a category of hemodynamics. So when you're in the hemodynamics under vitals, you want to start a new time. Okay, just like sometimes when you chart a vent check, you're going to right click and start a new time column because say you did your vent check 15 minutes ago, you want to reflect that it's not now, it's 15 minutes ago. So you'll, if that time doesn't exist in the columns yet, you'll right click and create that time. Well, you'll have to create a time under vitals hemodynamics that is the exact same time that you use to draw your FIC, which will be 750, right? In this case. When you have done that, you can find under hemodynamics FIC cardiac output as an empty box there. When you right click and add result, it'll draw in the calculated FIC. What you want to do, in my opinion, I'm highly recommending this, that you have the nurse find that result on Cerner after you draw it in. And the reason for that is you want to be concerned about reporting this properly, because if there's confusion and you say the wrong number, or or the nurse thinks you're talking about the cardiac index instead of the cardiac output, or there's a few different ways this can be miscommunicated. They might cut the drip, they might increase the drip based on erroneous reporting. So you don't want to ever kind of put yourself between that. On the same note, if Cerner is not calculating it, and the nurse might try to twist your arm and say, hey, can you calculate it for me? And then you'll, there's apps out there. Don't go down that road. The onus is on them to calculate it. Don't calculate it on your app, because who knows, you might be reporting the wrong number and it might cause the patient harm. It's their responsibility to do that manual calculation if they're going to be doing it. If they're going to need to do it. Any question?
What other, what reasons that Cerner doesn't calculate cardiac output if we do all the steps right? It happened to me once and it didn't pop up the number at all.
I don't know. If the reasons that I know of are if the column isn't timed to the right time.
Yeah.
But other than that, it should work.
Yeah, it just happened. Like the timing was all same.
Yeah.
It just didn't. So I had the nurses to calculate it themselves. Like they didn't like it, but.
Yeah, no, it's happened to me. It's happened to me. It doesn't happen too often, luckily. But yeah, it's always the pain, because you're usually in the middle of 4 other things and it's not working, and yeah. So I really don't know what to tell you about that, but you always, in any circumstance like that, try to involve another RT. Don't hesitate to call your lead. Because they would much rather try to fix that and those sorts of things in real time. Like especially if you make any error related to running a FIC, or you got the time off, before you even try to fix it yourself, just let your lead know, hey, because sometimes you can do more harm than good. And that's what they're there for, is to back you up in those sort of situations. So yeah, no, I don't have a good answer for you there. Any other questions on FIC? Okay.
So,
yeah.
So, sorry, for MI, so we just run it as mixed. We don't, we only run the venous mixed venous? We don't run the
Yeah.
arterial?
Yeah, that's what they tend to do.
Okay.
That's their basic protocol. I'm not saying that you might never be asked to run a 2-part FIC in MI, but they tend to just run the one side, and I don't know really even the math or the science behind that, but they just I think they take oxygen content, like they take the SAT as a measure. And so that's like a hybrid equation of the real equation. And but for whatever reason, that seems to be the trend these days, that they ask you to just run a mixed venous.
And then they don't, like, we don't have to do the calculation to Cerner. We
No.
just give them the actual values in there.
Yeah.
Okay. All right.
Yeah, because it's not going to calculate unless it has both parts. So a FIC and MI in that respect, if they only hand you the mixed venous side of it, then all it is really you just do the mixed venous gas and hand them the slip.
Okay.
Yeah. All right, trauma. So you got the cardiovascular surgeons, which you're going to have to meet. And then you have their nurse practitioners. And then you have the trauma surgeons that you'll meet and their nurse practitioners. So trauma is a whole different animal. They have their own considerations. What you need to know about trauma is that they typically like to SBT similar to our pulmonary docs. Similar or the same. You're going to still SBT their patients as a default. You're going to do basically the same care with vent management protocol that you do with the pulmonary docs. A couple things that I definitely want to make sure you're aware of with trauma patients is, again, collaborating with nursing. I'm going to give you an example here of how important it can be. This right here is something called the ventric. And so when a patient has a high intracranial pressure, sometimes they put a Camino or a bolt in there that measures the pressure, but then sometimes they also put a ventric, and a ventric is basically, like, the way I like to visualize it is it's like a big arterial kind of catheter that goes through the skull and is sits there in the CSF, and it'll drain out some of the CSF, and it'll kind of just equilibrate there in that column. So the patient's CSF actually is drained out to a certain degree, and then it'll be leveled in that column on that pole. So if you crank the head of the bed down, all their CSF will go pouring back into their head and they'll herniate. Or if you crank their head of bed up, you're going to drain all their CSF out of their head. So, not to make you paranoid, but you want to kind of be alert and oriented and communicating with your nurse. Like, I like to ask them right off the bat, hey, is there anything you need me to know about this patient? What's our plan? What are we going to do today? Like, all of those sorts of comments are going to get you very, very far in SI, because they're focusing just on this one patient. Usually they have one, sometimes two, but usually just one patient. And they know the whole long list of what's happening, what the goals are, all the considerations. You can't possibly really keep up with every single aspect of all of that. So you want to be real open with them and ask them, say, hey, is there anything I need to know? What's going on? What's the plan? How are we going to do this? Even if you know what you want to do with your weaning, it's a great approach to kind of word it that way, because it shows that you want to be collaborative with them also. Now, this ventric might be turned off to drain. And if it's turned off, then you can put the head of bed up or down or every which way, and it won't make a difference. But often, we don't know exactly what's going on, and we definitely don't want to train everybody on all the intricacies of how to operate a ventric, that's too much, right? So basically, we need to defer to what the nurse is doing with it and what we need to know. Trying to think of other trauma-related considerations. One thing that you may be asked for is apnea diffusion test. Have you guys heard of this? Apneic diffusion or apnea diffusion?
We talked about it during MI didactics,
Okay.
but I've never actually had to do one yet.
Okay. Anybody else? Let's look at the policy real quick. Oh shoot, what am I doing? Let's try this. So I don't want to spend too much time on this, but because it's boring. Okay, so just so you're aware of the terminology and roughly what we're talking about is the point of me bringing this up today. You're not going to ever do this alone. You actually need at least another therapist, if not 3 therapists, and the nurse to do this. So what I would encourage you to do is to print the policy. If you have this ordered, what will happen is a trauma nurse practitioner will roll up and say, hey, let's do apnea diffusion on this patient. You want to ask them to put the order in because we're going to remove the patient off the ventilator and assess certain criteria to see if they're brain dead or not. And the removing the patient off the ventilator could kill them in and of itself. So you want them to explicitly order this study. So you're going to ask them, hey, can you make sure the order's in? I'll get right on it. Next thing you're going to do is you're going to go to policy and procedures on the Sharp intranet, look up apneic diffusion, and you're going to print it. You're going to print a few copies. You're going to call the specials person or the lead and tell them that you have this ordered and try to arrange to have other RTs at the bedside, probably 2 others. And so the nurse has a small part in this. They're going to take vitals every 2 or 3 minutes during the actual. So you're just going to go through this, and I've done this probably, I don't know, 20, 30 times over my years, and every single time I read every single word on this policy because it's important. What you're actually doing here is you're doing a test to see if this patient's brain dead. When you deliver the result of this test, the next thing that happens is this doctor gets up out of his chair, calls the family, and tells them, yes, your loved one is brain dead based on this study. So you don't want to skip any steps. You want to make sure that you understand what you're doing and how to do it because it's very, very critical that we get the process exactly right. All that to say, it's not too difficult. It has some contraindications, as you see here. You don't want to do it on a hypotensive. You don't want to do it on somebody that has severe intrinsic pulmonary disease, that's still hypothermic, that's still under the influence, that has some metabolic issues, or is unresponsive to hyperoxygenation. So that's like a PF ratio less than 200. So the basic premise is that hypercapnia or high CO2 provides our stimulus for respiratory drive. Okay, so what we're going to do is we're going to take the patient off the vent and wait to see if they breathe. Okay, and the way we're going to do it is we're going to make sure the order's in, make sure there's no contraindication, share the nurse's responsibility. Okay, nurse, you're going to take vitals and you're going to be observing chest movement. And then we're going to get a baseline ABG. And the patient's going to be on 100%. And we want the ABG to be somewhat in the normal range. And here's the parameters. Okay. Now, the actual process to remove, we're still going to want to oxygenate. So we're going to take a suction catheter and we're going to tape over the thumb hole and hook it up to the flow meter. Okay. The way you just take an oxygen hose, stick the suction catheter in there, tape up the thumb hole, put it on 8 liters a minute, and stick it down the ET tube. So now they're off the vent, but there's oxygen flowing down in. Okay. Then we're going to do Q 5-minute ABGs. Okay. So after 5 minutes, we are going to get an ABG. So the basic premise is that if we get a CO2 greater than 60, then we stop the test and the patient's brain dead. Okay. If there's any spontaneous respirations, then we stop the test because the patient's not brain dead. They're breathing. That's the very thing we're assessing. So spontaneous respirations, or we get a blood gas after 5 minutes and it's less than 60, maybe it's 45. Then we get a blood gas after another 5 minutes and it's 48. Well, how the heck can that be? It's impossible. They must be breathing, okay? So they're not brain dead. But if after 5 minutes it's over 60, nobody's witnessed any breathing occurring, you can stop and you can call them brain dead. Okay. And then here's the termination criteria. So simple as that. So it's a little tricky when you're sticking because you want to stick right at the 5-minute point. You want to have somebody that can draw a good fast ABG. Somebody else will go and run it while the other RT stays in the room and gets ready to do the second stick if necessary. Questions about that? All right. Sorry, I know this is not terribly exciting stuff, but we are getting through a lot of good material here quickly. Let's see. I made this earlier today. I don't know if it's any good, but let me hang on a second. All right, 1 second. I jumped the gun. Oh, shoot. What am I doing? All right. I didn't mean to jump the gun there, but I wanted to see if you guys have any Heliox experience yet.
No.
0? Everybody?
Just once, a long time ago, and it was already like set up, but I didn't really get to really play around with it.
Mm-hmm.
None for me.
And I think when they set it up, nobody understood like how it was set up and who set it up. So that was weird.
Okay. That doesn't sound very good.
Yeah, it wasn't.
I'm going to go through a quick presentation here on Heliox, okay? I haven't even looked at these slides for about 4 years, so bear with me. This is what you need to know about Heliox, though, is there are definitely patients in my time that if it wasn't for Heliox would be dead, 100%. And some hospitals don't have Heliox. I think that Heliox should be standard of care to have it on hand at any major medical center and community hospital for that matter, because there are certain instances where it will absolutely save a patient's life. And I'm going to kind of try to outline that for you here. So benefits in general, airway resistance, worker breathing, gas distribution, intrinsic PEEP, aerosol delivery, improved CO2. Why not put everybody on Heliox? Because look at all these benefits. And I want to say, I know that this is probably in one of the slides coming up, but it's relatively benign. It has very few risks associated with it. So the big question is, yeah, it makes all of these things optimized, but does it really impact outcomes? This is a slide that I thought was interesting because I can't even decipher anything on it, except for if you look at, I'm not even going to try. Never mind. I don't think I ever could understand anything on this slide, but I just thought it looked cool. But there is something to turbulent, transitional, and then laminar flow, and you want to move towards more laminar flow, like less turbulence. So you want to be transitional in the upper airways, and then more laminar flow down and into the lower airways. So that's the goal. So what can it be good for? Croup, epiglottitis, laryngitis, foreign body aspiration, tumor, post-extubation stridor. In the lower airway, it can be good for asthma, COPD, CF, bronchiectasis, bronchiolitis. Again, why don't we use it on every patient? That's the question. So here's the answer. Data is insufficient to recommend Heliox for routine management of post-extubation stridor, croup, bronchiolitis, asthma, COPD. However, in rare patients with severe asthma associated with difficulty ventilating despite maximal other therapy, Heliox may enable oxygenation while waiting for the inflammation to respond to other therapies. Okay. Heliox is always a bridge. It's just a mechanical bridge to another adjunctive therapy working. So if, for example, a kid inhales a Lego, and the Lego is like in the right main stem, and despite everything we're doing, the PaO2 is like 40 and the CO2 is going sky high, Heliox is a good option because it's going to create more laminar flow. We're going to get more gas exchange. It's a lighter gas. And most importantly, this is a bridge to what? Getting that Lego removed, and then the patient's going to be okay. So if a patient, a patient kind of needs to get over the hump, and there's other therapies or an intervention that's going to happen in the future that's going to remove the obstruction or alleviate the inflammation, and the Heliox is there to optimize the situation until that point. That's when we use Heliox. So there's no evidence-based guidelines regarding the use. Rarely a therapeutic trial may be reasonable in clinical situations associated with marked airway narrowing, in which a temporizing therapy may provide a bridge to definitive treatment. So that's probably the right way to say what I just said in the rambling way. On the plus side, safe, very safe. Benefits are rapid. You'll know right away if the patient's responding. In the most severe, with the most severe obstruction or smallest anatomical airways, they might stand to benefit. A variety of evidence across many of diseases, that's not right, indicate that Heliox can decrease worker breathing, respiratory distress, dyspnea score, obstruction score, improving gas exchange and aerosol deposition. Oops. Something's covering here. 1 second. It not only improves patient comfort, but it might increase the duration of the therapeutic window, extra time for the medications to take effect. Kind of even another way of saying that again. Now, we use it invasively on the ventilator or non-invasively. On the ventilator, we want a closed system. So in other words, we can't use it on BiPAP. theoretically, it's possible to plug a BiPAP in, but you're going to run through a giant H tank in like 45 minutes. So we don't do it. If you want non-invasive, you're going to hook it to a vent, and you're going to run the vent in non-invasive mode, and you're going to do it with a non-vented BiPAP mask. Okay. If you're going to run it non-invasively, you're going to use the ARC, or the Asthma Rescue Kit. We used to have a bunch of green tubing and string it all together, but this is much better. So it looks like this. It's next to the Heliox kits in the equipment room. You want to target a total flow of 8, okay? So if you got 2 of helium, 6 of oxygen, 8, or 1 of helium, 7 of oxygen equals 8. So you want like a pretty close to 8 liters a minute running through it. If you see the ARC clip itself is screwed onto an oxygen flow meter, okay? And you see those 2 little oh, what did I just do? This must be touch screen. Those 2 little bumps on top there, that's where you're going to port in the helium flow. And you're just going to basically bleed in a couple liters of helium from the tank into this system. And there will be more pictures in a video. Again, we're targeting 8 liters. That green bag, that just fills up and it kind of helps conserve the helium. So the other little, if you look at the auxiliary gas nipple, it's called, then there's an alternative O2 inlet. It looks like that needs to be plugged. It doesn't. It has a one-way valve on it, so don't worry about that. See the one-way valve right there, the flap. Every ARC setup comes with this chart in it. So this chart's really going to help. Basically, if you want to target certain helium level, say you want to get a 70-30 mix, you go 7 on the Heliox flow and 1 on the O2 flow. All right, Graham's law, there's a less dense gas, so we're going on a cofactor of 1.8, so you want to realize that your actual ventilator return tidal volumes are going to be skewed if you're using Heliox on a vent that does not have the Heliox regulator. We have one G5 that has a Heliox regulator on it. Our rapid deployment, which you'll see in the next video, is for use in the ER. We need to get an H tank to bedside right away because it only lasts 30 minutes. And our 1G5 that has the Heliox blender on it, here's the menu. Basically, it has to go into standby. And when you're in standby, you can hit the system button and select Heliox as your gas source. And again, if you're using the 1G5 that has a Heliox blender, then all of the cofactors are worked in. So you can definitely believe your flow measures and your return tidal volume measures. Or you can go old school. Whoop. So this is basically showing you, so the oxygen side of this vent is just plugged into the oxygen high pressure, and the air side is plugged into the tank instead of the air. And that's basically how you set up Heliox on a vent. If the Heliox regulator G5 is unavailable, you can go ahead and run it right off the tank with the air hose. Okay. BiPAP, again, it's not recommended to use it with the BiPAP machines, but you can use it on the vent and put the vent in NIV mode with a non-vented mask. Be careful of one thing. You always want to make sure that your Heliox tank is an 80-20 and not 100% helium. always, always, always measure FiO2. Never run a setup without an FiO2 monitor in line. And it's for that reason. And then the biggest thing that's been a factor for us is the very simple art form of actually watching your PSIs and not letting your tank run dry. So as the RT, for if you have a setup that's running, and then your primary concern for that shift is probably going to be to figure out how long the tank's going to last and keep an eye on it and let your lead know. They'll get you extra tanks to bedside. They'll help you swap it out. This is #1 priority. More than a few times a tank's run out and the patient's been severely compromised, the RRT gets called, the physician's at the bedside, the tank's dry. That makes us as RTs look really, really bad. And so we definitely want to really focus on the aspect of making sure that our tank pressure is going to last. Okay. Any question before the video? All right, let's watch this. I'm going to put it back to speaker mode here, and then hopefully you guys can hear me. Okay, welcome. We're in the ED here with our Heliox quick deploy setup, and I'm going to use this as an example of how we do non-invasive. Obviously, the first thing you need is an oxygen source. There's a use the wall and a helium source as well for non-invasive. We need the ARC system here as the rescue kit. Looks like this. When you take it out of the bag, you will see this clip. The main part of the attachment goes to oxygen. So this is the oxygen flow meter. This could be the bedside oxygen flow meter. In this case, we're hooked with this high pressure hose to this oxygen source. And then we're bleeding in the helium right here from this tank. Okay. So as far as liter flow goes, there's a chart with the kit. We're supposed to be targeting 8 liters total. So it could be 2 of the helium and 4 of the oxygen, or 4 and 4, any ratio that will get you the FiO2 you want. Always need an FiO2 monitor with a non-invasive setup like this. So it plugs in right here. And so if you have, say, 30% oxygen, then you can chart that you have 70% helium. This right here is the nebulizer. You can fill it with what you need, and it'll continuously nebulize any medications that you have. This is a reservoir. You don't need to squeeze it or anything. It'll self-fill and kind of create a little extra volume that actually has helium in it, so the patient can't overbreathe the system. So when you're checking at the beginning of your shift in the ED, you need to look here at the helium pressure. It looks like it's 0, but this tank has an on-off switch. So you turn it on, looks like 1500, good to go. Turn it back off, and then bleed it out. So obviously when you're using this system, you want to make sure that you turn the tank on. Thanks for watching. Oh shoot. Oh shoot. All right, I'm back. Did anybody catch my mistake? Am I on mute?
No, we're all trying to figure out what the mistake is.
I said if we're trying to get to 8 liters, you can go 2 of the helium and 4 of the oxygen.
Oops.
4 plus 2 equals 6. Horrible. It's a good thing no one's life depends on me, right? All right, here we go. One more Heliox video. Again, it's not long, but it's going to give you a bit more background on the functionality of our G5 that does have the helium or the Heliox regulator on it. And so let's watch this real quick.
Connect the Heliox gas source to the ventilator. Put the ventilator into standby mode. Open the system and then the gas source window and activate Heliox. When Heliox is active, the alarm lamp is lit in blue. After switching the gas source, we recommend that you calibrate the flow sensor. Wait 2 minutes before calibrating the flow sensor to allow the mixture to stabilize. Make sure the flow sensor and tightness tests are completed successfully before continuing. Set the desired ventilation mode, adjust the parameters, and start ventilation. To switch back to the gas source air, firstly put the ventilator into standby mode. Open the system and then the gas source window and select air. Disconnect the Heliox gas supply. After switching the gas source, we recommend that you calibrate the flow sensor. Wait 2 minutes before calibrating the
Okay, so the reason I showed you that video is there is a nuance when you switch gas sources, you have to put it in standby first. So, and that's kind of hung several RTs up over the years, me being one of them, because it's not that super intuitive to actually put the vent in standby. Obviously, you're going to have somebody bagging the patient because like it'd be nice to be able to do it while it was on the patient. I think they did that on purpose because they don't want you swapping out gas sources while the vent's hooked up to the patient. So they want you to have somebody bag the patient. So then you put, and then they force you to put it in standby to access that menu. Okay. What I did is, so what you'll see is a green line for oxygen high pressure, a yellow line on the back, just like any normal vent, and then an additional brown hose. And that brown hose, I zip tied I screwed a Heliox regulator right onto that and zip tied it on there. So basically all you need is a tank and a wrench, and you can throw that regulator onto a tank and get going. All right. Remember, this is all just didactic, so this is background knowledge. I mean, what you want to do is get yourself into the situations where you're going to be able to get some hands-on, you know, seek it out, because especially for Heliox, they don't come around too often. I have one more thing that I want to review. How is everything going with event management protocol? I know that's a really broad question. I noticed that a lot of patients, it's not ordered. And so Chuck and I looked into it and we realized that when you order vent settings, it doesn't have the order sentences to prompt you to order the protocol. When you order ventilator, it asks you which version of the protocol do you want. But when you order vent settings, it doesn't. And then a lot of these physicians have vent settings as their favorite in their profile. And so what we're going to do is we're going to take vent settings out as an option. So yeah, so we're going to force anyone that orders a vent to either to to pick one of the protocols or explicitly say they want a non-protocol ventilator order. So that'll help a little bit. So there's something new coming down the line that I want to introduce you to. I don't want to kind of overwhelm you because it's kind of a lot of info I'm going to throw at you in the next 5 minutes, but this is kind of highly nuanced, so it's good maybe for me to give you a sneak peek of this, even though it's not ready for prime time. It's going to be a couple weeks, and it has to do with ventilator-acquired conditions or ventilator-acquired events, VAEs, or VAP, ventilator-acquired pneumonia. These are all different terms. Ventilator-acquired condition, VAC, is kind of the umbrella term of all of this terminology. And basically what it is similar to what I was describing earlier of the weaning window of 6 hours. There's certain measures that every hospital is being held to by CMS or Medicare. And basically, they're not reimbursing on certain situations. One of those is readmissions within 30 days. Huge penalties, multi-million dollars. Another one is this 6-hour window extubation. Another one is ventilator-acquired pneumonia or conditions. So the reason why we're concerned about this is we've had 12 this past year, and probably 6 or 8 of them are definitely legitimate. But more than a handful of them are actually just a nuance. So basically, what's happening is if we go up on the PEEP by 3 or more, or up on the FiO2 by 20% or more from baseline, and we are not able to wean back down in the next 48 hours, we automatically flag this person with a VAC, and then it starts moving down the pipeline where we have to evaluate for a full VAP, and we end up not getting reimbursed for that entire patient's care, even though in a few of the cases, all we did was went from a PEEP of 5 to 8 and 40%. Because we went from 5 to 8 and we stayed there, it triggers the VAP. Now, everybody knows that this criteria is crazy and it's not even that appropriate, but this is kind of like the thing we're working with. This is left over from Obamacare. Every health system is up against this. Is struggling to make sure that the insurances still pay them. And so we are forced to, even though there might not be a clinically significant reason, we're forced to create something that we're going to call a VAC rule. And the rule is if you go up by 3 or more on the PEEP, or you go up in the FiO2 by 20% or more, then in every 12-hour shift subsequent, including the shift that you go up, you want to trial back down if possible. So that might only mean going from 8 to 7. That's okay. And if we can get a sustained trial back down for at least an hour, then that untriggers us for the VAC. So there's definitely going to be a lot more to come on this. This is what the badge card's going to probably look like right here.
Are the doctors aware of this?
Yeah. I mean, this is spearheaded by Dr. Sachs, and he's got the SRS on board. We're getting trauma on board right now, so everybody's going to be following the same deal. So
is it possible to look at the O2? You know, a lot of them don't always have reasonable SpO2 expectations. Maybe looking at expecting lower SpO2s in order to maintain.
So about that, it seems like we're moving towards going 92 to 96 for every patient. But like I said, none of this is nailed down yet. But look over here to the left, you'll see new VAC rule, right? If you have to increase from baseline. Now, baseline merely means that the rule doesn't trigger unless the vent's been at certain vent settings for about the first 48 hours. And then if there's increase from that 48-hour baseline, right? And when that happens, we want to trial the patient lower FiO2 or PEEP for at least an hour within every 12-hour shift. And whether it passes or fails, we want to chart the trial, start and stop time and settings in Cerner. Okay. And then over on the right side, what I'm thinking about doing is having the more experienced RTs check in on the other RTs and maybe ask the following questions. So you'll know ahead of time to prepare for these questions, but you'll be asked, is vent management protocol ordered on your patient? And if so, is that protocol being followed? Are any of the carve-outs to the protocol, are those addressed in the orders? And then the most important part is the part we were talking about. If the PEEP and FiO2 have been increased by equal to or greater than 3, equal to or greater than 20% in the past 12 hours, has a trial been performed of decreasing the PEEP and FiO2 per VAC rule? And that's the rule we just talked about. So the aim is to decrease the PEEP so it's less than 3 or the FiO2 is less than 20% from the baseline. Okay, so that could mean 1 centimeter or 5% increments. And if it works, you just hold it there. If it doesn't work, then you know, say it only goes 5 minutes. Chart that the start time, you know, in interactive view, and then chart that you went back up. And then you could put a flag and comment if you wanted to. Tried it, it failed.
So you're going to have a part like our daily screen for our SBT in our eyes and in our interactive view.
No, it'll just be like right where you chart your vent settings.
Okay.
It'll just be, okay, yeah, FiO2, I went from 40 to 35%, or PEEP, I went from 8 to 7%. And then it either works and then you leave them there, or if it doesn't work, then you just chart that you went back up.
So it's only triggered if the increase is 3 or greater. So if the increase is 1 or 2, that doesn't trigger it.
No.
Okay. And then what about the COPD population? Because they throw everything off.
Well, their baseline will be higher. Yeah, believe me, like that goes on a long list of about 100 reasons why this is absolutely ridiculous. So basically, we are navigating an environment that is not based on logic, nor is and nor is it like clinically significant. Like, I was in a long conversation with Dr. Sachs where he was basically like, why aren't the RTs just following the vent management protocol and continuing to assertively wean down according to the criteria? And basically, I'm telling him, hey, well, look, if we went from 5 to 8 and the patient's been kind of going between 40 and 50%, it's not going to be anywhere close to the top 10 things on my list that day to get that patient back down to 5. Actually, like it might not be clinically even the right thing to do to push that patient down to 5.
And you might have trouble from the nurses saying, would you please go back up? Would you please? Yeah.
So we're going to do, definitely there's going to be education rollout with this. It's not live yet. But just for your own knowledge, you get a sneak peek of it. But nursing is definitely going to be educated as well, and the pulmonary docs are going to be on board. That was my big ask is, hey, we can't have a RT asking to decrease, calling and saying, oh, I tried to wean the PEEP from 8 to 7 and have them kind of have the physicians not understand what's going on and kind of blow them off. We need every physician to also know what the final goal is with all of this, and we need common language, and then we need a consistent approach, or it's definitely not going to work.
Good luck with that, Tice.
Yeah, well, thanks, appreciate it.
Yuck.
Yeah. All right. So, questions? Nothing? No one?
Not to beat a dead horse, but the COPD population as far as getting different SAT parameters, because for some of them, 88% is awesome. And maybe we need to look at those lower SATs in order to help us achieve our goals.
As well as ARDS, like we want to target lower for ARDS. So it's just going to be the protocol default at 92 to 96. So any physician can change their SAT goal, and it doesn't mute out. Like, remember the PEEP FiO2 protocol, we said that if there's any variance, then the protocol's off. Well, that's not the case with vent management protocol at all. They can order the vent management protocol and they can say, but I want to hold at 10 of PEEP.
So hold the lettuce.
Yeah. So, I mean, they're still the ordering provider, so they can make whatever carve out they want, but we still want to have our PRN, ABG, and our CO2 goal. And, we can still benefit from having our hands untied for all of that. So.
Okay.
So that, I mean, that's the idea. We'll see how it goes. Anyone else? Anything else? A lot of info. Make sure you put 2 hours of training time on your time cards. Don't forget that. You want to get paid for today. And then you're going to basically hit up your leads and say, hey, I need a couple shifts. Who's on night shift? Q? Anna, are you on night shift?
I'm on night shift. Q is 2.
Okay. So yeah, I don't know if you want to maybe come to days to do a shift. I don't know how you feel about that, but it's probably less likely that you'll get to wean a heart or land a heart, because often, like, yeah, the landing part, especially with INO, you might want that experience.
Yeah.
But on the flip side, you really want to meet the people, the nurses in SI, but also the physicians, and those might be around during the day. I'm gonna have to talk to Coletta about that. She might feel like it makes sense for you to do one of the 2 shifts during the day.
Yeah.
So for me, I don't really care, but I really do want you to get out of this precepting what you need to feel comfortable,
Yeah, for sure.
Yeah. Cool. All right. Anything else? All right.
Are we going to have another touch base anytime in the future about some of the like I said, the ECMO, the neuro measurements that they kind of want us to know, that kind of stuff?
Yes, it's kind of a moving target at the moment. They're training nurses to monitor ECMOs in the absence of perfusionists right now.
Yikes.
And so I'm still trying to calibrate how integrated respiratory is going to be in all of that. It's possible that we could be a part of that program as RTs. It's probably not likely in the first round, of course. But what I'd really like to do is get some experts to come and talk to us, and because what do I know? I'm not a perfusionist. Really what it comes down to is you're going to get the education the same way as we all have, which is at the bedside from perfusionists, from nurses. They're sitting there all shift with a clipboard, jotting down numbers. They're dying to talk to you, believe me, you know. So that's how we all learned about ECMO. I'd encourage you to ask questions. You'll have a lot more access to the knowledge in SICU. Although there are ECMO patients in MI, that's kind of a recent occurrence. The real knowledge base is in SICU. So you'll have a lot more exposure to learning there. So
Those handouts you sent out were really good. That went over all of the ECMO and the ins and
okay.
outs.
Okay, Kimberly, did you get those?
I don't remember. I'm trying to think if I remember getting those.
I can resend that email if you like.
Please do.
Okay, I will. So I'm crediting back 3 minutes to your lives for free. Unless anybody has any other questions.
Thank you.
Thank you all for joining. Okay.
Thank you.
Bye-bye. Take it
Bye.
easy.